Hey, welcome back to our last part of our pre-work for pregnancy and chronic illness before the TBL on Tuesday. So jumping back in, we're going to start looking at our preferred antihypertensives. So unlike asthma, we do have some clear recommendation on antihypertensives in pregnancy as compared to our non-pregnant patients. So as pharmacists, it's really important that we are screening our patients for pregnancy, asking if they are pregnant or plan on becoming pregnant, and counseling them that if they are on some of these medications that we don't recommend, which I will get to, um, that they're aware that if they become pregnant, that their therapy would need to change, but that we do have appropriate options. Just the best options for them may need to change. So we'll start with our preferred antihypertensives. So we have first line and second line recommendations. So our first line recommendations include our preferred agent of labetalol for hypertensive control in pregnancy. We additionally have the first line recommendations of methyldopa as well as nifedipine. This may be one of the few places that you see methyldopa used. We even then it's not something we typically see used even in our pregnant patients, but knowing that it is an appropriate option for first line management. But like I mentioned, labetalol is going to be our preferred option. Second line, so if the patient is needing something additional, we do have the options of hydralazine and hydrochlorothiazide. However, these are not our first line options. So good to know, and that they are appropriate options if additional blood pressure control is needed, but would not be our first choice. As I mentioned, we do have some indications here of some harmful antihypertensives. So starting first with ACE inhibitors and ARBs. So our ACE inhibitors are a category D in our first trimester of pregnancy and the category X in our second and third trimester. This is basically the classification of risk in pregnancy as well as lactation, the general scoring that we use. So in this case, this is just talking about in pregnancy being the category D and then category X. So we do need to avoid these in our pregnant patients. Some of the risk factors of using it in pregnancy were fetal growth restriction, neonatal renal failure, intrauterine growth restriction, as well as death. So if a patient is on these medications, we want to make sure that they are switched off of them once they know they are pregnant, or even if we know that they're planning to become pregnant, that we are discontinuing these ahead of time and getting them on the appropriate regimen. When it comes to ARBs, so ARBs are category D throughout all of pregnancy, but we still want to avoid. Another one to mention is our beta blockers. So beta blockers are category D, specifically with atenolol, there was the fetal growth restriction. And then with the class as a whole was the fetal bradycardia and respiratory depression. We also want to mention the mineralocorticoid receptor antagonists. So those being our spironolactone and eplerenone. So spironolactone being a category C and eplerenone being a category B. Regardless, we still want to avoid these in our pregnant patients. So to make sure you're familiar with all of these medications that we want to avoid in our pregnant patients, specifically the ones in purple, but it's good to know all of them. So we'll start off with chronic hypertension therapy. So as I mentioned, this is going to be hypertension that the patient has before they become pregnant. So they already know they have hypertension. They're probably already on therapy. So this is when that preconception planning comes in. So we want to obtain their blood pressure goals. Blood pressure goals may vary between pregnant and a non-pregnant patient. So making sure our goals are aligned. And then reminding them to maximize all lifestyle changes, as we know non-pharm and blood pressure can go a long way. We want to switch to safer medications once they're planning or confirmed. So like I had mentioned with the ACE inhibitors, we want to try to avoid those once we know they're planning to become pregnant. And then reminding all of our patients, specifically the ones with chronic hypertension, to be checking their blood pressure at home and keeping a log. So like I mentioned, with the changes we may see during pregnancy and blood pressure, we can expect the blood pressure drop in the first 22 weeks. So this is when that home log and home blood pressure monitoring could become important. If they are going to be experiencing blood pressure drops, we might then need to adjust their medication and actually have them on a lower dose than what they were on prior to becoming pregnant. And then when it comes to that mild hypertension, it's pretty controversial if it should be treated or not. And I think that's where it comes in with having all of the different blood pressure cutoffs of when we should start to treat. So it really becomes a conversation with the patient and risk versus benefit of treating the hypertension versus the risk of the patient becoming hypotensive if we overtreat. It's always good to consider lifestyle changes first, but additionally, the risk of hypertension is very real as well. It's important to acknowledge that there are different recommendations of when to deliver the baby based on the hypertension and what we are doing for the hypertension. So these all come from ACOG. So acknowledging that if the patient's on no medications, they can go almost full term to 38 to 39 weeks. If they're controlled with medications, we might need to push it a little bit earlier to 37 to 38. Our preeclampsia and our preeclampsia with severe features is when we need to see that earlier delivery happening at 37 weeks or as early as 34 weeks. So now moving into preeclampsia. So preeclampsia is a medical emergency. So this box here highlights how we can diagnose preeclampsia. So typically the blood pressure, let's say, was typically normal. They have no history of elevated blood pressure, or even if they do have chronic hypertension, my apologies. If it's managed and we see this elevation, that would be the first telltale sign. So having a blood pressure greater than 140 over 190 on 2 different readings 4 hours apart, or a blood pressure greater than 160 over 110 at a one-time reading, and one of the following. So they can either have proteinuria, so this would require a urine sample. In that urine sample, they will complete a urinalysis that may show protein greater than 300 milligrams per 24-hour urine collection, or having a protein to creatinine ratio greater than 0.3. So they could have that with the elevated blood pressure, or if they do not have the proteinuria, meaning their protein was not greater than 300 and their ratio is less than 0.3, if they have a new onset of any of the following, so that being thrombocytopenia, which is going to be our low platelets, renal insufficiency, so we might see this with an elevated serum creatinine or poor urine output, impaired liver function, so we may see this on their liver function test, or if they appear jaundice, pulmonary edema, so having shortness of breath or swelling throughout the lower extremities, or a new onset headache unresponsive to medication, that being, if they take something over the counter to help with their headache and it is not resolved, that could be an indication of preeclampsia. This kind of walks you through the preeclampsia pathophysiology. So typically it comes about with early abnormalities in the placental vasculature. So we might see this 20 to 34 weeks or later. So that's saying that preeclampsia is typically something we won't see until after 20 weeks of gestation. And then there's several different reasons for why this may occur. It's just important to know that there are several different pathophysiologies. So with preeclampsia, it can be progressed to some more severe stages. So we have severe preeclampsia, HELLP syndrome, and eclampsia. So severe preeclampsia is diagnosed as a blood pressure greater than 160 over 110 with end organ damage. So some of the things I highlighted, the renal insufficiency, liver dysfunction, pulmonary headache. We could see this in our central nervous system with the headaches that I mentioned, or if that even progresses to blurred vision. The renal dysfunction, once again, just being the elevated serum creatinine with or without proteinuria. Similarly, the pulmonary edema, liver dysfunction, hematologic dysfunction, and severe abdominal pain. So just kind of outlines what those end organ damages could actually look like and the specific cutoffs. From severe preeclampsia, the patient could then progress to HELP syndrome. So HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. This is when we can then have an increased risk of morbidity and mortality, as it is a major cause. Lastly, the patient could progress to eclampsia. So from preeclampsia to eclampsia, eclampsia being seizures. So it's important that we consider preeclampsia prophylaxis. The chart below, I'll jump back up, but the chart below kind of outlines the level of risk of the patient developing preeclampsia, their risk factors, and then the recommendation. So it's really important that we know how to assess our patients and if they qualify for prophylaxis. So typically when it comes to starting the prophylaxis, we need to remember that this would occur at 12 weeks. So 12 to 28 weeks, we need to assess them if they're at risk for preeclampsia and need to be started. In terms of our options for preeclampsia prophylaxis, we have typically aspirin. So aspirin works by decreasing our thromboxane. The dose is typically 75 to 150 milligrams daily. So it'll be our low dose aspirin of 81 milligrams is our typical dose, but could be anywhere within that range. Like I mentioned, we want to initiate that in week 12 in our moderate to high risk patients below. It's also important that we need to discontinue this 5 to 10 days before delivery, as it does have an increased risk of bleeding. Calcium is also an appropriate option for preeclampsia prophylaxis. And then just to highlight some of the specific risk factors. So it's important to know if the patient has a history of preeclampsia and what that outcome may have been if it happened in a previous pregnancy. If they have chronic hypertension, if they're type 1 or type 2 diabetes, if they have renal disease, or if they have an autoimmune disease. Additionally, some of the risk factors for moderate could be obesity, having a family history of preeclampsia, if they're age 35 years or older, or some other personal history factors. Low risk factors would be a previous uncomplicated full-term delivery. So if a patient had already had a pregnancy and delivery with no complications, we do not recommend that they get low dose aspirin. So once again, I just want to reiterate the importance of knowing when we need to give our patients prophylaxis for preeclampsia. Coming back to preeclampsia and having it be a medical emergency, some of the treatment considerations. So the patient would need to deliver at 37 weeks if without severe features. So these severe features being the end organ damage and the progression to HELP or eclampsia. If either of those develop or if the end organ damage gets too severe, they would need to deliver sooner than those 37 weeks. If they are delivering sooner than 34 weeks, this is when we can consider giving the mother corticosteroids, so typically betamethasone or dexamethasone. And this is kind of to improve the fetal lung maturation. So think before they're going to deliver, we're going to give them every shot they have in terms of the fetus to really help them develop as much as they can before they deliver preterm. This table goes over the doses for the antihypertensive agents used for urgent blood pressure control. So once again, mentioning preeclampsia is a emergency. If they were to come into the emergency department, we would be giving them these medications via an IV. So we just outlined here the doses with our main drugs being labetalol, hydralazine, and nifedipine. You don't necessarily need to know the doses, but just acknowledging that in an urgent situation of preeclampsia, we need to give them these medications from the IV, and these are our options, as well as acknowledging the onset of action and when we can expect that blood pressure to start to come down. Lastly, for their management, aside from the blood pressure, we also want to work on seizure prophylaxis. So like I had mentioned, preeclampsia can then progress to eclampsia, where the patient could develop seizures. So for this, we would want to give IV magnesium sulfate 5 grams over 20 to 30 minutes, then followed by 1 to 2 grams an hour. So this would kind of prevent the progression to seizures. Then moving forward, so post-delivery, we want to continue their treatment after delivery, and we want to continue to monitor them very closely. There's outlined here the specific recommendations for monitoring, but just recognizing that even after delivery, there could be complications that we want to watch for. But lastly, I just want to touch on breastfeeding and hypertension. So it's pretty similar to our antepartum. We just need to acknowledge that here methyl-dopa would not be used. There was an increased risk of postpartum depression in patients that used methyl-dopa antepartum and throughout breastfeeding. So our preferred agents would be, once again, our beta blockers. So our labetalol that the patient was on once they were found to be pregnant. This has the least amount of transfer into milk as far as the whole class of beta blockers, which is why we suggest labetalol. In terms of our calcium channel blockers, nifedipine and diltiazem are also recommended in breastfeeding. And then as for our ACE inhibitors, they are okay to be used in breastfeeding and postpartum, but only are enalapril, captopril, and quinapril. It's also important to note that diuretics can lower milk production. So a lot of times this is a concern for new mothers. And so we want to take that into account. So if we can use something other than a diuretic to help control their blood pressure while they're breastfeeding, that would be preferred. So just to wrap up, to go over the pharmacist's role. Pharmacists have a huge role, as we've been able to highlight throughout this lecture, in helping women plan a safe and successful pregnancy. This can come into play in pre-planning and then their chronic disease management during and even after their pregnancy. We can do so by evaluating their medications once we are aware that they are pregnant and making any recommendations. We can also work on educating women of childbearing age about safe medication and optimal chronic illness control. So this can start as early as pre-pregnancy. So once in that planning stage, how we can optimize their chronic conditions before they become pregnant. All right, that is all from my portion. I've included the references here for you guys. So if you want to go to the guideline yourself, there is a lot of great helpful diagrams and different resources I think can help you guys learn better if there's a certain area you're unsure about. Sometimes seeing it in a different format helps. I hope this lecture was helpful for you. If not, please let me know any questions you may have. I will see you all on Tuesday for our in-person TBL. We'll be working through some cases together. Thank you all.